Hi, everybody. Welcome back to the long edition of our interview with Christiane Kuhl. Christiane Kuhl is the chair of radiology in Aachen, one of the oldest cities in Germany, Europe.
That's right.
And she's a in breast.
The great.
Yeah. And she's a world leader in breast MR, as we all know. So it's an excellent opportunity to have a good longer chat with Christiane on her vision on screening of women with dense breast using MR.
Thank you.
So what's your take on
that? I think it will be very important actually to explain that we need improved screening, because if you look at the, say, public discussion and the criticism regarding breast cancer screening as it is today from our colleagues in oncology or epidemiology, what you usually hear is that overdiagnosis and false positive diagnosis would be our most important problem, which is simply wrong. It is wrong because despite mammographic screening being practiced in Europe and even in a quality assured version in Europe for the last 2 or 3 decades, breast cancer continues to be the most important cause of cancer death in women. And that explains that there's still, I think that the actual problem, the magnitude of the actual problem hasn't changed. So there's a clear need to improve early diagnosis of breast cancer. And then we need to discuss how to achieve this. And,
May I log in here? Or you? Yeah.
Absolutely.
Let's talk a little bit about yeah. It's the beauty about these interviews. They're so super interactive. Christiane, if you agree, let's talk a little bit about over and under diagnosis, because this is something I think we have to know when we talk about MR screening, don't we?
Exactly. I mean, I actually term the word underdiagnosis just to explain in a single word what I think is the most important problem that we face right now. People talk about overdiagnosis, and overdiagnosis means that we, when we screen for disease, tend to also pick up cancers that, even if left undiagnosed and thereby left untreated, would never progress to a life-threatening disease. It's difficult actually to prove the amount of overdiagnosis that is associated with screening, because you can find out only by using long-term follow-up of breast cancer incidence and mortality in a society. So you have to compare breast cancer incidence like in the 1970s with today's breast cancer incidence. But as everybody knows, there are other factors that may increase breast cancer incidence, such as demographic factors. People get older, so more people will be diagnosed, have a chance to develop breast cancer. Anyway, overdiagnosis is a very complex construct that is still obviously very much known by our colleagues, not only by radiologists, but also by our colleagues in oncology and epidemiology. And people seem to have gotten the impression that mammographic screening is fine, and we already, with mammographic screening, we have a problem with overdiagnosis. So adding more sensitive imaging methods would only increase overdiagnosis. That is the logical shortcut that they do. But that is totally inappropriate. It's inappropriate because underdiagnosis, as I said, which is failure to identify existing breast cancer early enough to prevent life years lost from breast cancer, underdiagnosis is the main problem that we face right now. And that's actually even easier to measure underdiagnosis than it is to measure overdiagnosis, because you can see underdiagnosis directly in patients who have interval cancers, because that means we fail to identify existing cancer. And as we all know, interval cancers are known to be more aggressive, more rapidly growing than the average breast cancer, which actually led to the fact that for the longest time, people thought that you can't avoid interval cancers, because people thought, okay, the fact that these cancers grow rapidly means that they likely started to grow only after the last respective screening mammogram. That was the explanation until the very moment when we used MRI for screening, when we realized that we can see all these cancers much earlier. and then almost altogether avoid extinct interval cancers, which would be unattainable if it was true that they started to grow only after the last respective screening round. So what it actually tells us is that mammographic screening is particularly blind for the rapidly growing cancers. It tells us that one important reason why mammographic screening may not have been as successful as we all would have wished it to be is that mammographic screening has a sensitivity profile that is actually not in accordance with, but even opposing clinical needs.
This is a beautiful point made on the underdiagnosis and the understanding of interval cancers. So the cancers which develop in between or we detected in between. And actually, this is two different meanings
Absolutely.
of the same wording. And this is beautiful pointed out by you. So talking about the interval cancer rate, then we quickly end up talking about the pivotal trial who showed that interval cancer rate dropped thanks to MR and screening with dense breast. That's a dense trial. And for those of you who have not watched yet the interview of Carla Gills, the PI of the dense trial, make sure to follow our YouTube channel. So this is, I think, a major step that we could prove that we could reduce underdiagnosis with the dense trial. In your study, the ECRON style together with Chris Comstock, you used basically a similar approach, but you had ACRC plus D breast, right? So you had not only D one. So let's talk a little bit about this future evidence about the dense breast in general. So the ACRC and D. What's your take? What's your future? Because
I think the EA1141, the ECOG ACRON study that you just referred to, is a nice example to demonstrate that it's not only density that is a problem. Actually, it is okay to start with recommending MRI for screening in women with extremely dense breasts, also because it's an easily definable subgroup. And it's certainly them who have an increased risk of breast cancer and a far reduced chance to find that cancer by mammography. So that is actually a useful start, but it is only a start. And the EA1141 included a cohort of women who actually, in the vast majority of cases, had ACRC breasts and even some Bs. The latter is explainable because the inclusion criterion, the eligibility was checked on the respective last screening mammogram. So we had some who in between had progressed with their involution. So we even had women with ACRB breasts. And it has already repetitively been shown that the additional cancer detection in women undergoing MRI for screening matches, so to speak, the distribution of breast densities. If you go back to the paper that we published, I think in 2017, on the use of MRI in women with low risk, no family history, no nothing, when you look at the one of the figures, actually I think nicely showed that the distribution of women with only MRI detected cancers matched exactly the distribution of the ACR categories in the entire cohort. So we had a slight tendency for some more additional cancers identified in women with D breast, but it's certainly true that also women with ACRC can harbor additional cancers that are undetectable by mammography. And even TOMO, as you know, the EA1141 was not comparing mammography with abbreviated MR, but TOMO. So it was meant to be a future-proof study to use the latest and greatest achievement in mammographic screening. So taken together, density is one point, especially the masking effect is certainly and understandably highest or strongest in ACRD. But all the data that we have right now tell us that it is not only density, but it must be something in addition. It might be architecture. And as you know, if we use AI to analyze mammograms to predict the individual risk, which is very accurately possible today, they also select women who have an ACR B or C breast. So that, I think, is the future. The future is not to use only density to stratify women or to identify women who need more than regular mammographic screening, but to use contemporary methods of risk prediction, which would be AI-based mammographic texture and density analysis, to identify women who need more than mammography. And that will be a larger group of women. But when we go back to the DENSE trial and the cost-effectiveness analysis of the DENSE trial, I think we can move the the inclusion criterion according to which we should offer MRI for screening. We can much broaden, and we can have a much wider interval, I think, of risks and still be cost effective. So in the future, I think we will use mammograms or maybe even MRI studies to predict the individual risk and then offer abbreviated MR for screening.
So going beyond the very small indication ACID, which is, as we know, a small group, to a much broader indication.
Yeah, if you go back to your own clinical experience, I mean, you identify breast cancer not only in AC or D breasts, and actually, depending on the distribution of ACR categories, way more women with ACRC develop mammography occult breast cancer, simply because there are much more women who have ACRC breasts. And that is, so to speak, a missed chance to greatly improve early diagnosis. And we need to greatly improve. We don't need a slight improvement. I think we need disruptive change here. We need to really change gears. We need to really change methods and the entire approach to greatly improve or reduce breast cancer mortality.
Thanks, Christiane. This is a beautiful statement. And in the next part of our interview, I'd like to refer to your beautiful background, which reminds me to my Star Trek years, to boldly go where no one has gone before. Because now we basically have the guidance. We talked about overdiagnosis, underdiagnosis. We know that you probably can fly with this Starship much faster and better. But still, going on a mission is always very risky, and there's a little bit of adventure. So knowing your thing, knowing the engineering stuff is good, but translating it into action, this is a different part. So if you agree, I would really love to share some minutes with you talking about how you can do that. We know and we can see in the background that you are the president of our society, in the next year, German society. So the political aspects are also important.
Sorry?
The political aspects, like the social economic.
I mean, that's what actually in the EUSOBI guideline, we actually do acknowledge the fact that it will take some time to establish screening programs that employ MRI on a broader scale, and specifically quality assurance screening programs, because I think it should go without saying that we need a similar quality assurance program for MRI screening as we also have it in place for mammographic screening, if not even more. And I would so actually I think the call made by EUSOBI is to the individual European societies of breast imaging in Germany, France, Italy, Spain, is act on this now, do it now, and try to set up your own translational trial, so to speak, where you try to find out the best way to put this to practice. If you start with extremely dense breasts, it may be that you can even go along with the existing capacities of MR systems. I think that is at least the case for the Netherlands. It might be different for countries like France, but it might also be true for Germany, for instance. Once we move on to include more women in screening programs, I think, I would hope that the MR vendors really work on dedicated systems that I don't mean, with dedicated, I don't necessarily mean cheap. Hopefully they should also be less expensive, but I don't mean cheap in the first sense, but I would mean optimized, that are optimized to really help make a high volume screening possible. Because right now, for the time being, it makes little sense to cut down the MR acquisition time down to 3 minutes or so, but then still take 10 minutes or more to get the woman on and off the table and in the prone position, which takes quite some time, and then have the breast position in the breast coil. The takes at least, say, 10 minutes. And it's pointless, therefore, to even push the acquisition time to as low as it was proposed by the MIP-FAST proposal that we made back in 2014. So only when we have dedicated systems that are optimized to get women to help to separate, so to speak, the preparation of the woman, or speed it up and make it also a more say acceptable experience for the women, I think then we will be able to expand the role of MRI for screening. So it must be a partnership with industry to develop these systems now. And I think it is true to say that the industry actually waits for us to issue guidelines that makes it for them an attractive business case. So it's in a way a circle, so to speak.
And another, I think, a very important point. I mean, I have a privilege to talk to a chair of a huge department of radiology. You're not only doing breast, you're interventional radiologist, you're neuroradiologist, so you're doing prostate, so you can compare all that. Mm-hmm. So is it really true, that's like a provocative thesis, is it really true that we don't have the capacities? I just checked with a friend who is working at Siemens what actually the percentage of capacity which we really allocate to MR. Right. Breast, we're doing 60% neuro, which is great, but we don't save too many people there. We're doing a lot of MSK.
Take lumbar spine as an example. Okay, we do lumbar spine MRIs all over the place, although we do have sufficient evidence to say that lumbar spine MRI is not needed in virtually all clinical scenarios, except for very few with specific neurological symptoms. But otherwise, all the lumbar spine MRI are just making nice pictures of something, of a diagnosis that can also make clinically, actually. So I'm absolutely with you, and I can see, I see the very same issue here. But the fact is, I think you will not be able to turn the wheel backwards in this regard. So I think it will be difficult to change current clinical practice so as to do less lumbar spines or shoulders or elbows. But I do think that if you translate the concept of abbreviated MR to a much broader fraction of our patients, that would be really helpful and would release capacities that we can then invest in MRI screening. Or put it this way, if the use of our magnets were guided by the level of evidence on the diagnostic relevance of the respective diagnosis, I think we would do breast MR more than almost likely any other application of MR.
It's a beautiful point. I didn't actually wanted to argue the past. I just wanted to show basically a showcase that people were able to raise capacities. And I also I had an EMR last week. I'm very happy I had it. Also, there's no level A evidence because that was really useful. But if it was possible in 90s and to install scanners from this, we should be able in the 20s to install more scanners for breast MR. Particularly, we have that. I really think the capacity issue is virtual. I mean, we're doing.
Also, if you keep in mind that, for instance, people, if people like to compare MRI, and then it's my impression right now that contrast enhanced mammo is heavily pushed. And then people again start to think, should we really use the level of 1 evidence that we finally eventually have on the use of MRI for screening? And maybe should we wait, because maybe contrast enhanced mammography will be the imaging method to use. So there's an additional there's an additional reluctance that I feel on really starting to use MRI for screening in clinical practice. That is explainable by the currently likely unsettled role of contrast enhanced mammo. And I think the two, of course, are no competitors. I think that contrast enhanced mammo has its role in diagnostic assessment, for instance, maybe even for staging. Although I have difficulties to understand why contrast enhanced mammo would be indicated for staging when MRI appears to be not indicated for staging in the same patient. It's actually difficult for me to understand. But when it comes to screening, I think it will simply not be justifiable to use contrast enhanced mammo on a broader scale, an imaging method that combines, so to speak, the disadvantage of mammography in terms of breast compression with the disadvantage of mammography with need of contrast agent, disadvantage of MRI for need of contrast agent, plus ionizing radiation. I'm not exactly sure that this is the way you should go. And I'm only mentioning this because it seems sometimes like this, it seems that people argue for MRI, we need to establish the entire infrastructure and build or purchase many more magnets, which you don't have right now, don't have the resources to buy. But with contrast enhanced mammo, the same holds true. A regular mammography machine is not able to do contrast enhanced mammo. You need the exact similar, say, investments also to be able to do contrast enhanced mammo. So long story short, I think it is now time to really use the evidence that we finally have and have been able to collect on the use of MRI for screening. There's no excuse not to use it now. I would hope for the women and the matter of breast cancer as a whole that we will enlarge the number of women who will have access to MRI screening greatly, and use modern methods of risk prediction to select these women, and honestly talk to women and explain what the choices are, what the pros and cons are, what the advantages and side effects are, and come up with something that is actually established in the world of treatment, and that is shared decision making.
It's a beautiful take home, particularly putting the patient in the center of all of that. It's obviously the scientific background, social economic background is important, but after all, it's the patient we are caring for,
right. and it's important. It's important to realize that women may have different preferences. There are women who don't want that extensive screening or early diagnosis, and others who are keen to have the very best for them. Not all actually are. I always hear people say, well, shit, it's very difficult for screening, it's a complex issue, and explaining what overdiagnosis entails and underdiagnosis is a time-consuming thing. But then we have to keep in mind that, as I said, in the world of treatment, shared decision-making means that people who are sick, who are not at their usual best, need to make very important decisions regarding treatment that are even more complex and have more implications and can have disastrous complications or implications. And they need to do so within days, usually. Whereas decisions regarding screening can be made in the safety of your home, right? Years before the first screening round is due. So I think that is greatly underutilized. The methods and technologies of shared decision-making, and that is something where we as radiologists are responsible and should come up with explanatory videos, materials to help women understand their choices.
Yeah, and responsibility of us as radiologists, not just providing some sort of test, but in the center of decision-making. This is beautiful. This is abroad with you in the future. So thank you very much, Christiane, for being with us today. I really enjoyed that. I got a feeling we could talk here for hours. But, because the topics, the vibes are great, the atmosphere is wonderful, and the topic is so broad, and it is really, really interesting, not only for the sake of science, but for the sake of the patients.
Okay.
But at this time, I have to close that chat.
Thank you.
Beautiful chat. We started about with overdiagnosis, covered underdiagnosis, talked about technical stuff like how we can break it down. It's not only the screening time, it's all the overhead. It's time which is so important, but most important is the patient, what we have to care for. Well, it's a long story, and looking at the background would say, make it so,
right.
Warp 7, engage, and
start.
See you soon.
Start the adventure. Okay.
And see you, and you guys make sure to follow us at our channels, which is YouTube, LinkedIn, Instagram, and Twitter, where we're gonna post all the other videos, and it's really worth, because all the other partners we talked about, our president, EUSOBI, Ruth Pineapple, Dance Trialist, PI, Carla Gills, Ritziman, first author of recommendation papers, and Chris, who did the beautiful study on comparing TOMO versus MR, we've been MR together with Christiane. They all made a different point on this whole spectrum. So thank you very much for being with us again.
Thank you.
Christiane.
Take care.
You all. Bye.